The time to manufacture sufficient vaccination doses to vaccinate, a population of 7 billion is going to be on the order of several years. So either you keep yourself isolated as a nation for that entire period of time until everyone's vaccinated worldwide, or you open yourself up to risk. Those are the only two options, really.
Hello there, and welcome to Wrong Ways Columbia Cast. Now, today's guest came to public prominence early last year for questioning the efficacy of widespread lockdowns as a measure to halt the spread of coronavirus. In October, he co-authored the Great Barrington Declaration, a proposal arguing for an alternative public health approach to dealing with COVID-19 through focused protection of the people most at risk. Dr. Jay Bhattacharya, Professor of Medicine at Stanford University, Director of that institution's Center for the Demography and Economics of Health and Aging, and also a Research Associate at the USA's National Bureau of Economic Research. Thanks for taking the time to talk to us.
I'm delighted to be here. Thank you for having me.
And you're looking very relaxed there as well. That's the most important thing when you're on Wrong Ways Columbia Cast. But anyway, Dr. Jay, whatever about the rights and wrongs of lockdowns, the fact of the matter is your Great Barrington Declaration has been largely ignored across the world by public officials making coronavirus containment decisions. And what's more, in the likes of the US, where you are, the UK, my home country, Ireland, and my adopted home here in Colombia, there are those who say that we didn't lock down hard enough. Now, I think I'm right in saying that 4 months on from the publication of your declaration, you still stand by it. So what have lockdown advocates been getting wrong from your perspective?
I think the main thing is that they have not respected the most important scientific fact about this disease, which is the age gradient in mortality and risk. For people who are younger, the disease is actually, for children, for instance, is not particularly dangerous. The flu is more dangerous. For people who are older, it's much more dangerous than the flu. Every 8 years of age, the risk doubles, mortality risk doubles. Something on there. It's maybe 7 or more 9, but something like that. That fact is incredibly important. So if you're over 70, the survival rate from this disease is 95%. 5% is a very high risk of death. If you're over 80, it's even much higher. If you're under 70, the survival rate is 99.95%. Right. So that's fact one. And that's established based on 100 seroprevalence studies and other studies like that of looking for the how many people have evidence of having had the infection in the population. So we know that the disease has this steep age gradient. At the same time, the harms from the lockdown are uniform, and actually not uniform. There's some populations have had it worse than others. Children, for instance, where in the United States schools have been closed, there are studies that suggest 5.5 million life years lost just from the school closures alone. Because if you skip school, you have to lead shorter, less healthy lives. We've stolen that from our children. People with cancer skipped cancer treatment. People skipped cancer screening. The psychological harm is enormous. 1 in 4 young adults seriously considered suicide. The suicide rates in the United States are almost certain, actually worldwide, are certain to go up because of the lockdown. Isolation causes these problems. Isolation caused huge amounts of devastation, even in older populations, in nursing home settings. The worldwide, 130 million people are estimated to be at risk of starvation by the UN as a consequence of the economic harms from the lockdown. 1 million extra tuberculosis patients dead worldwide. I mean, the list goes on and on and on. These sort of lockdown harms. So what's one to do with these facts? For people who are older, COVID is a really deadly condition. We should be protecting them. We should be devoting all of our resources to protect the people who are at highest risk from COVID. This focused protection is the key idea of the Great Barrington Declaration. Protect people who are older. For people who are younger, the problem is you have the lockdown harms are much worse than COVID. not saying COVID isn't harmful in younger people. There's some, for instance, element of there's some folks who get longer term conditions from COVID that can happen. But on net, the lockdown harms are worse than COVID for the younger population. And so for them, the lockdown is an immoral imposition for younger people. And so the Great Barrington Declaration calls for a lifting of the lockdowns for younger people and focused protection efforts for older people. And it follows from the two key scientific facts, in my view, about the epidemic: the age gradient and mortality, and the existence of severe lockdown harms.
Well, okay, but then how exactly do you go about that focused protection? We could say at this stage, we're talking late in the game now that vaccines have been rolled out, and we're all hoping that is a success. But with variants, who knows, that may not be the case. So you were born into a low-income country. I'm based in a low-income country where you have 3 to 4 generations, the norm in one household. How do you go about that focus protection? It's very difficult in those circumstances. It's something that could work in a high-income country more easily, you would imagine, but in a country like Colombia or like India, that would be much more difficult.
Yeah, it is more difficult in those settings. It's absolutely true. I think you can start with a low hanging fruit, like in Colombia, but as well also in many places, there are concentrations of older people, like in care homes and nursing homes. We should have, even from the earliest days when we saw the data from China about this age gradient, been working to protect those locations, because that's where a lot of older, vulnerable people live. And it's a very logistically easy thing to do when you have a concentration of people that you don't have to go out and identify separately, right? By the way, I should preface this: the vaccines now are a perfect tool for focus protection. We should prioritize people who are older for the vaccine, and that provides quite good protection. We can go back to the variants as well, because I think the evidence is suggesting the vaccines are still quite good against the variants. And with this mRNA technology, it's easy enough to alter it so that it covers the variants.
Okay.
Anyway, but we can come back to that discussion. Let me answer this question first. So for people that live in the community that are at high risk, I think the lockdowns, you think of them as protecting them, but actually they haven't, right? We have this two classes of people in the lockdown: essential and non-essential. And the lockdowns, if you're essential, it takes no account of whether you're high risk or not. If you're 64 and you have diabetes and you're a store clerk, poor country or not poor country, you go work. Lockdown or no lockdown, right? The lockdowns have put poor people who are at high risk in harm's way. So I think there are policies you could implement to stop that, right? So for instance, you could ask or require employers to provide accommodations for their older workers who are at high risk, so they don't have to face the public and they minimize the risk of COVID exposure. Now you brought up the question of multi-generational homes, and that really is a problem, right? So that's a very difficult thing. So there's a few things I think, ideas that I've had for this. This is something I actually kind of expected the public health community at large to engage in, rather than just saying it's impossible. That's been one big disappointment to me about the Great Barrington Declaration response, that people haven't sort of seek to engage to answer the question you asked me together. It shouldn't just be me answering this. It should be the public health community working together on this. Anyways, my ideas are if we provided hotels, for instance, for homeless people during the lockdown. We could provide we can offer people who live in multi-generational homes a place to stay if someone in their household is exposed, right, temporarily while the exposure is getting cleared up. We can offer, there've been regulatory burdens in approving the use of at-home antigen tests, cheap at-home antigen tests. So, I'll just give you an example. If I want to go visit my mom, who's 80 and is high risk, I could check myself with the antigen test. A cheap antigen test. If I'm positive, I don't go. If I'm negative, I go. Right? That puts power in the hands of the people living in the house to make decisions about what's safe and not safe at a local level. We actually haven't. It's been taken a very long time, at least in the United States, to approve these tests because the results of the tests are difficult to connect to public reporting. Right? So if I'm positive, I don't maybe I don't want to be quarantined for 14 days. I'll quarantine myself until I feel better. So I'm going to resist taking the test if there's especially when there's a test with false positives. I'm going to resist taking the test because there's this risk of this false positive resulting in a quarantine that I really don't want to pay. So I won't take the test before I go visit my mom. The linkage between the testing and the public reporting has created a barrier to addressing this problem of multi-generational homes. Right? If we just allowed people to privately know if they're positive or negative, they can take private actions to protect their loved ones. That would work much better, I think. Whereas I think this idea that we should publicly report so we can force isolate, it's appealing to a certain kind of person, but it actually, I think it has this consequences about the incentives to test that have been negative, that have actually harmed our older people.
Okay, well, I have to ask, Dr. J, like you talked about people not getting on board your ideas, like coming up with other public health officials of how you could do this, that it shouldn't have been all on your shoulders and those of you part of the Great Barrington Declaration. But this might seem counterintuitive, but in one sense, because we're both on the same page about lockdowns, was it the case that politicians and other public health officials, that with a lockdown, okay, it's widespread and it affects everybody, well, as you said, not equally, but in terms of shutting down, it just shuts down completely, that it was kind of an easier thing to do rather than this separating of society into high risk, low risk, that if you go, okay, we just shut down everything. And then politicians can go to the public and say, look, we took the hard measures. This wasn't easy. We didn't want to do this, but we took these decisions in your greater interest. Whereas the smarter, more intelligent thing would be what you called for in the Great Barrington Declaration, but it was harder to implement.
Yeah, I mean, I think this is a difficult epidemic. I mean, we have to acknowledge that. I mean, there's going to be mistakes. An argument that we pick a simple policy just because it's simple doesn't really appeal to me. This is a disease that has very heterogeneous effects. By age, for instance, we've been discussing also the lockdowns. I think we have to think about a heterogeneous policy that takes advantage of its heterogeneous sort of nature. The right tool for the right people would be the right way to think about this. And this is not something that's new to public health. Public health does this all the time, right? In public health, we don't tell a 10-year-old to worry about type 2 diabetes. We just don't. Useless. And creates panic for no reason, right? It would create, whereas we would tell a 40-year-old or 50-year-old to worry to watch your weight, think about think about those kinds of those things about diabetes, right? So I think that kind of targeted messaging comes natural to public health. So it kind of surprised me that that the public health community has adopted this monolithic approach to the disease when the harms are so high from the approach itself.
Yeah. Go on.
Yeah, I think so. I've been thinking about why that is. So I think there's two kinds of goals that you might think about in the context of something like COVID. So one goal, and I think is actually in the back of the heads of many public health officials, is zero COVID. This idea that we can eradicate COVID somehow, we can suppress its spread to the point where it's no longer it exists in the population. The other goal is essentially to learn to live with COVID, right? To have COVID be a disease that's the fifth or sixth human coronavirus circulating in the population, right? Or it's one of the other 200 and some diseases that infectious diseases that are commonly afflict mankind, right? It's just the 201st or whatever it is, whatever the number is, right? Those are the two goals, possible goals. If you accept the second goal, then the only question is, how do you minimize harm, the total net social harm until you reach that endpoint? That's the only question, right? So in that setting, I think the Great Barrington Declaration is quite attractive because it accounts for both the lockdown harms and the harms of COVID to the population. It balances those so that it chooses policies that seeks to minimize the total harm from all of those sources.
Okay.
On the other hand, if you've adopted zero COVID as your end goal, well, then any harm that comes from the policies themselves count for nothing. All that matters is zero COVID.
Of course,
right? Frankly, it's kind of a strange goal. Like, if you think about this disease, would this be the disease we would choose to eradicate if we could? Tuberculosis kills more people than COVID every year almost than COVID has, or at least in the last 100 years, that's certainly the case. There's even the more recent history. If you look at polio, I mean, that's actually eradicable. We were I think on our path to eradicate it until our COVID control policies came along. There are a lot of diseases that we would pick before COVID to eradicate, I think. I think people are thinking about COVID as people who have the zero COVID goal. They are thinking about it as the thing to do, because I think in rich countries, it's a shocking thing that there could be an infectious disease that could afflict so many people. We're just not used to rich countries thinking that way.
Yeah, we've been kind of almost distant ourselves from death in many ways in the richer world. Yeah, of course. So on the eradication point, though, there will be the lockdown advocates that will point to the likes of Australia, New Zealand, Taiwan as well, and other such countries. There's banging and smashing going on in the background here. I hope people can't hear it. I don't know what's happening close to me. But anyway, they would point to that as a route to eradication. But it would seem kind of late in the game now that we can even get to that stage here.
Yeah, I mean, first, let me just note an irony in this. So if you're going to eradicate, you need a vaccine, right? And any country that let's take New Zealand, which effectively got near zero COVID almost the very beginning of the epidemic, you would never be able to develop a vaccine because there aren't enough cases to test whether the vaccine works.
Okay.
So there's some irony in this just from the outset, right? That in a sense, these countries are relying on other countries getting sick to develop the vaccine in order to implement their desired policy. It's kind of a beggar thy neighbor epidemiology policy, if you will.
Mm-hmm.
Okay, so now if let's leave that irony aside. How did New Zealand get to zero COVID? I think, in a sense, I worked on these seroprevalence studies very early in the epidemic in April. One in Santa Clara County, one in LA County. And it's interesting there because in April, early April, we found that there were almost 40 to 50 times more infections than cases already, right? So there were in Santa Clara County, 50,000 infections, whereas the public health officials had found 1,000 cases. In LA County, I think like 600,000 infections, where the public health officials only found a few thousand cases. The disease was already incredibly widespread in early April when public health officials in the United States started deciding to do the lockdowns. That was not the case in New Zealand. In New Zealand, I think there were very few infections, in part because they're an island nation, in part because the international travel in and out is less than on a per capita basis. In any case, that their lockdown actually did have some shot at eliminating all the infections. That wasn't true in the United States. That wasn't true in Ireland. That wasn't true in the UK. That wasn't true in most of Europe. And it certainly wasn't true in Colombia or India. And now East Asia generally is another case we should talk about at some point. I think there's some interesting things to think about there. Like why did East Asia as a whole do much better? In some cases without even a lockdown, like Japan. In any case, so the key question then is, if you're thinking about zero COVID, is are you at a place where really there are very few infections, for a novel disease? Then you have some shot at zeroing out the thing with a lockdown. We are far past time for that. The world is interconnected. Let's say Ireland isolates itself, achieves zero COVID. Well, until its entire population is vaccinated and continues to be vaccinated routinely, because a few people could, who knows how long the vaccination immunity lasts. You have to be isolated as a nation, and we're talking about years, right? Because the number of the time to manufacture sufficient vaccination doses to vaccinate, a population of 7 billion is going to be on the order of several years. So either you keep yourself isolated as a nation for that entire period of time until everyone's vaccinated worldwide, or you open yourself up to risk. Those are the only two options, really.
Yeah, well, as I said, we're both on the same page in terms of the efficacy or otherwise of lockdowns. And that's one thing I say, that maybe there was an argument for them at the very start when this whole thing was beginning. But once it's out there in the general public, it just does not seem like the right move whatsoever to lock down. Now, you did talk about or mention the East Asian countries. So what was different? Was it because of their experience of SARS and things like that that they had a head start in other countries, or was there a mixture of different factors there?
I mean, I think there's some element of there's some evidence. So first of all, I think some places, like let's take Africa, right? So Africa, I think partly because they have such a younger population, relative to the rest of the world, they are relatively protected from the death rates from COVID because of this steep age grading and mortality. That's true for some, but now Asian countries, that's not true. East Asian countries, not true. China's aging. Japan is very old. Taiwan's very old. You would think in principle that they would face quite a high risk of COVID. And yet they in general, almost no matter where you look, Japan is probably the most shocking example, like probably the oldest country on the face of the earth. And yet they've had relatively low COVID mortality. And they didn't really have a lockdown, right? So, what can explain this? I think there has to be some element of pre-existing immunity in in East Asian populations to explain it. There's really no other explanation that works, because there's huge heterogeneity in the policy interventions, and yet you see basically the same outcome. All of these sort of countries close by one another. I don't know. I don't think the scientific community has figured out the exact source of it, but the existence of it must be there.
Yeah, obviously there is something at play there. I guess it's something that in years to come, with better studies and greater knowledge of this whole pandemic, we might find that the keys to that, why exactly that happened. But yeah, it is.
In the Europe and the Americas, we didn't have it. I mean, it's very, very clear. Like there isn't a single country in Europe you can point to that really has had incredibly low East Asian-like mortality outcomes, no matter where you look. Same thing with the Americas, right? So that it's. I mean, some countries have had lower mortality than others, but not nearly the same level of low mortality that you see in East Asia.
Yeah, interesting. As I said, I've said this in a few interviews as well. It would be interesting to see what future historians say about our handling of this whole pandemic. Maybe they'll all come down on your side, Dr. Jay. We shall see. But we mentioned the vaccines earlier, and I just wrote a story yesterday and as soon as I published it, news came out that I think it's the Pfizer vaccine is actually early studies showing that it does prevent transmission, like up to 67%. Because that was one of the questions I had in the story I wrote about the vaccine. I basically said, just to give you a summary of it, that I would not be in a rush to get the vaccine. It's not that I'm anti-vaccine. It's just, number one, I'm not high risk. Colombia has a 5-stage rollout of the vaccine beginning on the 20th of February. I'm in the last stage as things stand. So I do not expect to be in a position to get it until the end of the year at the very earliest. And my current visa expires in November, so I may not even be here. But anyway, that's another story. But yeah, so now that the vaccine is seen, at least the Pfizer one anyway, to prevent transmission up to 67%. I mean, that's another reason for people to get the vaccine if they feel like me. Well, I'm low risk, so what's the point in getting it? Would you be pro getting as many people vaccinated as possible?
So I think to me, we should use the vaccine as a tool for focused protection at least initially, right? So my 80-year-old mom should be vaccinated long before me. Mm-hmm. Right? I think she is at much higher mortality risk than I am, and I've told her to get vaccinated as soon as she can. California, unfortunately, has done a very poor job of vaccinating its older people, prioritizing its older people for vaccination. Other places have done better, like Florida, for instance, have prioritized older people. I think Florida is now already done with vaccinating every single person living in a nursing home in Florida, and most people living in assisted living facilities. So I think that's a policy choice. I think it is absolutely the case that we should vaccinate our older population immediately, as soon as possible. We should also vaccinate. And this is something that California has done, and other places have done, is vaccinate people who care for people who are older, right? Because there's a high risk of spread in healthcare settings. So I think that's the first priority. That should be done immediately. Yesterday, if possible. For the rest of the population, the fact. So I saw that report. It's interesting because that was an open question from the initial Pfizer reports about whether there actually was evidence that vaccination reduced the ability to spread the disease. That report looks pretty good. Like now, it seems like it. I mean, a priori, you would have thought that if you reduce the symptoms, asymptomatic people spread the disease much less efficiently than symptomatic people. It wouldn't be surprising that it would slow the spread of the disease. So in a sense, it's not a surprising result, but it is a very encouraging result. Now that we have that result, I think you could think about strategies where if you know which groups of people are more likely to spread the disease, then you could prioritize them after you've prioritized the elderly and people who work in hospital settings and care and nursing home settings. You could prioritize them. So I've seen some evidence that people in their mid or late 20s are more likely to spread the disease than across generations than others. So you might, but that evidence is kind of equivocal, right? Compared to the absolute fact, because you don't know, different countries might have different people who are more likely to spread the disease. It's going to be country to country, state to state, region to region. It's hard to predict exactly. Whereas for a fact, there's this doubling of mortality risk by age. So, another point of view, which I could see is completely reasonable. Again, after you've vaccinated the elderly, is let's just go down the age ladder. First do the 60-year-olds, then the 50, then the 40s, then the 30s. Once you get to 20s and teens and younger, it's actually not clear from a personal point of view whether the vaccine is a good idea, right? So for children, the disease is not particularly deadly, right? It's more children died of the influenza last year in the United States than COVID. Wow. That's with the flu basically disappearing in the fall. So it's interesting. So I think I'm not going to, and the vaccine hasn't been tested on children. I personally am not going to have my children vaccinated with it until I find until I see much better evidence on it. I personally would be happy to get vaccinated. My wife has she cares for cancer patients. She's gotten vaccinated. Okay. My mom still has not gotten vaccinated, which is really making me unhappy. So I think it's this is one of those things where we want to, again, it's focused protection. We want to think about the risks heterogeneously. We have this fantastic, amazing tool in the vaccine. Let's use it intelligently.
Yeah. Interesting you should say that. I have a San Francisco friend here. She's married to an Irish man and they have a newborn baby, and her Irish husband is all for the vaccine. She is not. She's about my age, about 36, 37. And their newborn baby, I think about maybe 9 months old. And she said, Millie, the baby, is not going to get the vaccine either. But interesting. I guess another group that you'd add to that, because here next week, private colleges and schools are going to go back, limited capacity, and then the week after, public schools. So I guess getting teachers as well vaccinated will be another group to focus on.
It's funny because there is this evidence from lots of places that children in school settings spread the disease to their teachers at very low rates. Right, on the basis of evidence, schools have stayed open throughout the epidemic in Sweden and much of Europe. So I don't know that teachers have to be a super high priority, but I'm not against it. I think if that's what it takes to get teachers back in the classroom and get our kids learning in person again, I think that's a good investment. I think part of it, and you're alluding to this, is using the vaccine to allay people's fears, because that is another central fact about the epidemic, which I didn't mention, but is really important. I think a lot of the support for the lockdowns, a lot of the people's keeping your eyes and ears closed to any alternative, it stems from this fear. So and I think the consequence of the fear for our children, with our schools closed, are absolutely devastating and enormous. So if we use the vaccine to get rid of that fear among the people who teach our kids, that I'm in favor of it.
Yeah, 100%. And of course, in a country like Colombia, where the ability to have virtual classes, I mean, my internet stayed steady for this interview, Jay, but it doesn't always stay steady. And I'm considered to be living in a richer part of town, in inverted commas. So to get children back into schools, well, say get them off the streets, I sound like an old man, but you know what I mean. It's like, it's just what they've missed out. And here it's been practically a year without in-person classes. So the damage.
I am an old man, so I can say that. Let's get our kids off the streets and back in school. I think it's funny that the inequality of this is just mind-boggling, right? So richer people can afford to hire tutors. They can afford to all kinds of substitutes for the school. They can send their kids to private schools, which are open throughout the United States. But poorer people, there's no way. I mean, we have this enormous educational inequality gap in the United States to begin with, and it's widened to an extent that I think is going to be impossible. Just let me give you one small thing, which is literacy. Right? How do you teach a 6-year-old or a 5-year-old to read over Zoom? The answer is it's very, very almost impossible. We're going to see an illiteracy problem that will have this economic and race gradient, because the richer people can substitute for that. They can hire tutors to help, or they can spend their time with the kids themselves or something. Whereas the parents of poorer kids, they have to go out to work. They can't hire tutors. The kids won't learn to read. So I think this is one of these. Again, it's just a relatively small thing but it is big in another sense, right?
Of course.
So I think this is one of these things where we're just going to be regretting this for a very long time. But I do think the vaccine, if we use the vaccine to get our teachers back to teaching, that I think that's a good use of them also.
Okay. So then how optimistic, and obviously I'm in South America, you're in North America, how the vaccine rollout is going to proceed will probably be far different there compared to here. Although I think Colombia, amongst the Latin American nations, has a much clearer pathway. That's why they've been able to secure, I'm not sure how many million, but that's why they're going to start the vaccine rollout on the 20th of February. So based that all countries get some sort of vaccine rollout going and inoculate their vulnerable, how optimistic would you be that come, I don't know, August, September, that we're going to see a kind of more cautiously more open world?
Well, I fully anticipate the United States, once its older population is protected with the vaccine, which could happen by the March, April. I think states will advance. So at that point, the death rates will come down very sharply, and it will be very difficult to maintain the lockdowns. I think that the demand for the lockdowns is related to the death rate, and the more focused protection we do, the less demand there'll be for the lockdowns. Is my theory. And I fully anticipate by the summer the United States will be almost entirely open. I think you're right. Colombia has done better, but much of South America, that's not going to be the case. I think it's going to take much longer than August to get the vaccines out to the older populations in much of South America, and that's true for a lot of places as well. The vaccines, I think there's this Johnson & Johnson vaccine, the single dose thing. I think the manufacturing is a little bit easier maybe than these new mRNA vaccines. Maybe we can expand those. I think a lot of the world will still be not vaccinated in August. So I think that what the kind of tensions we'll be seeing then is places that are vaccinated will still want to close borders to places that are vaccinated. I think there's going to be this sort of half and half world where half are still going to have these lockdowns and half are not going to have. We already sort of see this with Sweden in Europe or Florida in the United States, where we have this weird half and half world, right?
Yeah.
And I think that will just get accentuated as more and more countries come out of lockdown.
You raised an interesting point there, and I'm asking this completely as a layman, and it might be a silly question, but I'll ask it, and I'm not sure would you have the answer, but somebody asked me this after I published that vaccine story yesterday, that if you have the formula, how you make the vaccine, why can't they tell the pharmaceutical companies here in Colombia, this is how you do it, and get it rolled out here and make it here in the territory. I guess there's all sorts of legal issues at play or whatever.
Well, there's some intellectual property issues, but really the main thing is just you're injecting this in billions of people. You have the manufacturing standards are really high, and you want to be sure you it's easy to get it wrong. So some of those regulations make a lot of sense because you don't want to inject something that causes harm in anybody. So you just, I think, and so it's difficult to have a vaccination. It's difficult to manufacture these kinds of vaccines in any case. Like in the flu, we have a set process that we're used to, but that we just don't have that kind of process set up. I am in favor of local manufacture if it's possible. Absolutely, I think a lot of countries are no one wants to be reliant on another country for its source of something so vital like this. So I think this kind of local manufacturing makes sense. It's technically hard, and so we're talking years in many places.
Okay. Just briefly, do you think that the UK then played a little bit fast and loose with their process, although it now seems to have worked swimmingly for them and they're ahead of the pack?
I think they were very careful. I mean, the AstraZeneca vaccine you're talking about, right? I mean, that's a pretty good vaccine. I mean, they tested it pretty well. I think it is an absolute miracle that we got to this vaccine so quick. So many vaccines so quickly. Like I thought about this last April when I first started doing those seroprevalence studies about the vaccine, and if you'd asked me then my expectations, would it be possible that in February of next year we're actually talking about the vaccine being vaccine distribution issues, I would have told you there's no chance. Normally the vaccines take years to develop and test. They were developed almost immediately, and the testing is what took a while.
Yeah.
And so it's an absolutely remarkable feat of science that first it got developed so quickly, and that the testing was done at scale so quickly. So we know a lot about these vaccines. Are the vaccines tested as much as they would have been in normal settings? The answer is no to that, simply because there just hasn't been time. Right, we've only had a few months of testing, but on the other hand, given the harms from COVID itself, it's sort of the right policy choice, I think, right? So the standard you use for what to say yes or no to depends on the severity of the disease. We have a very different standard for chemotherapeutic agents, saying yes or no to them, than we do for diseases that don't have such deadly effects, right? So I think it was a wise regulatory choice to let up on that. It does put us in a little bit of a funny position because we don't. In the United States, it's called an emergency use authorization for the vaccine because they're not fully vetted the same way they're full. But on the other hand, of course, you need that. I mean, you shouldn't wait until you have the perfect evidence in the face of a deadly disease like COVID.
Yeah, well, I think the bureaucracy in the European Union, which of course the Republic of Ireland is part of, is playing its hand at the minute, but we'll see what happens over the next few weeks. But just also on that case on the vaccine and it being approved, it's also to allay, because you said the deadly disease for those elderly, but across the board, it's to allay the fears that we talked about too, because now people who are kind of lockdown advocates, but at least if the vaccine gets rolled out, it's to allay those fears that we can get back to some sort of normality.
Right.
Yeah, well, that is the hope. Now, a couple of questions. I know you've been very generous with your time, Jay. Final questions. I need to ask you about Anthony Fauci, because he's almost kind of been revered as the second coming of Christ in the United States in many ways by a lot of people. But he hasn't exactly been a rock of consistency either. Now, I don't know the veracity of this video, but I think it's true. I saw that last March he was talking about masks, saying how they weren't that effective to use. And then I think it's just a month ago, he recorded saying that we should be using more than one mask, maybe one or two masks and things like that. But he's become this kind of cult figure in the United States. And he's now, of course, Joe Biden's chief medical advisor. And he still is director of the National Institute of Allergy and Infectious Disease. What are your thoughts on Dr. Has he done well if you were grading him?
So I have on my bookshelf a textbook for Harrison's Internal Medicine, where he was one of the chief editors. I've respected him from the first time I learned about him in medical school, and so it's been to me a great disappointment to see how poorly he's performed in this epidemic. I think if I had to identify you've identified the lack of consistency, the sort of like tailoring of the message to meet the political needs as opposed to like what the science is saying. I mean, there's some aspect of that you could criticize him on. To me, the worst things have been his absolute blindness to the harms of the lockdown. Right? He doesn't seem to see that these policies that he's arguing for have these devastating consequences. There's no hint of that in almost anything I've seen him say. And I don't understand it. I mean, it seems like to me that should be foremost in the mind of any public health official providing advice to governments or anyone else about this. So I think that to me is probably the single biggest failing of his that I've identified.
Yeah. Well, I was going to say equally, Ireland's chief medical officer, I'd put him in the same bracket. My word of the year for 2020, it wasn't quarantine or lockdown or COVID, it was monomania. And it just coincided with I was reading Crime and Punishment, and that was the kind of big word in Crime and Punishment about the monomania that the main character had. And actually, something very interesting at the end of Crime and Punishment, where this pandemic comes out of, or this virus comes out of Asia and infects the world, and it put men against men. This was all written towards the end of the book, and I just thought, well, this is exactly what's happening. When was that written? In 1880 or whatever. But yeah, I certainly agree with this. Not to look at the bigger picture, and that's been my frustration with this. When I explain my point of view, and people just don't seem to understand, and I don't know why.
Funny to think about Fauci as Raskolnikov, I guess. I mean, it's fine. Yeah. I mean, I think I agree with you. This monomania is really a central problem, right? Like, we've forgotten that there are many, many other important difficulties in public health, priorities in public health that we ought to be thinking about now. And to just let that go for a full year or more is a abdication of responsibility on the part of Tony Fauci. I say one other specific thing that I think he's failed at, is specifically is in his role as the head of NIAID. So the head of NIAID has it's basically it helps set the agenda for research in infectious diseases. And this is a success. Just to give the devil his due, is he did prioritize vaccine development, which was a good idea. Obviously, it's paid off some dividends here, but he didn't, for reasons I don't understand, didn't prioritize the testing of other treatments for the disease that could have been useful early, right? So of course there was this whole political mess around hydroxychloroquine. But there are other ones, ivermectin, fluvoxamine, a whole series of other drugs that are cheap and widely used, and I don't know if they work yet, and that's a problem. Like, the NIAID should have already run large-scale trials of these things that look promising in other settings. Instead, they have fallen down on the job. We've done very little in the way of these kinds of large-scale evaluations of these kinds of early treatments. We should be further along there than we are, and that falls on Dr. Fauci as head of the NIAID.
Yeah, and again, as a layman, but I heard this today on the BBC talking about vitamin D, also just making sure that your levels of vitamin D are appropriate.
There the evidence is quite good, actually, but again, it's not the NIAID that's like played the central role there.
Okay. Yeah. Now, Dr. J, I know you said that you hope there comes a time soon that you won't be talking about COVID-19, and we all hope that will be the case. And there was something I did want to get into more depth on, but you've been too generous with your time. But you are, as I mentioned, the director of Stanford's Center for Demography and Economics of Health and Aging. And just if COVID-19 is thought as anything, because it is an ageist infection on the whole, this is an area that we really do have to focus a lot of attention, investment, planning, how we're going to deal with elderly populations as our planet, as our human population gets more elderly in the years to come. So you have a lot of work on your plate with that.
Yeah, well, I think in some sense the COVID-19 was a stress test of how our ability to support older people when there is a deadly affliction affecting particularly them, and in many ways we failed. Like China is getting older. Japan is already the oldest population on Earth. Fertility rates are dropping worldwide. Europe is getting. We're moving from a population pyramid that's a pyramid with many young people and very few old people to a population column where there's a very large fraction of the population is older because they're more long-lived. We're going to need different healthcare structures and different ways to finance healthcare, different ways to support for the elderly population that we're going to have in the coming 2, 3, 4, 5 decades. COVID-19, I hope, serves as a wake-up call about how poorly prepared we are for that worldwide. Right? We just have not done a good job in protecting our older populations. And the old system of relying on, we relied on extended family to care for our grandparents. That is going to become less and less feasible with shrinking family sizes. And yet the newer systems, which involve institutional support for old care homes and whatnot, that also seems to have failed in the COVID-19 era. So we're going to need some creativity here that hopefully someday when COVID's over, I can start to think about again.
Yeah, focus on that. Exactly. Well, and it's something I've given a lot of thought to as well. Indeed, Peter Hitchens on the podcast a couple of weeks ago, and he talked about like today's hospitals kind of being a free-for-all is one issue, that we should have more segregation going forward, especially in light of what we've seen with COVID-19. But it's certainly an area that we need to, I think, give a lot of focus and attention to in the years to come. And maybe, as I said, Dr. Jay, we'll have you back and talking about that and not COVID-19. That would be the plan.
That,
I take it, do you engage in any social media or anything like that? Have you withdrawn from all of that stuff?
I'm on Facebook, but because I have a very large number of cousins and uncles and aunts in India and friends from various parts of my life. And so I like to see baby pictures on Facebook. I try as much as I can to not put any of my, although I failed a little bit at Facebook, but not any of my professional work on Facebook. I don't think I could handle the emotional stress of Twitter, so I just don't do it.
I'll nearly drink to that as well, but one has to promote their podcasts and things, so I do engage in it, but I wish at times I didn't. Speaking of that, people can get in touch with me at W. Corrigan. That's my handle. But Dr. J, I appreciate you giving us all that time, insightful as ever. Unfortunately, as we said, a view that doesn't always get out there in the mainstream media, but we'll do our bit to try and spread the message as best we can. So thanks for joining us. Okay, all the best. Until the next time, guys, it's ciao ciao from me.